Okay, well, good evening, everybody, and welcome to another one of our Igennus webinars. Today's webinar is a practitioner's guide to the Opti-O-3 biomarker test. Before I start, just to make sure that everybody can hear me, I'll do a quick sound check. So there's a small chat box down in the left-hand side corner. If somebody could just acknowledge that I'm coming across loud and clear. Super. That's what we like to hear. Okay, so today is going to be a sort of pretty practical, sort of hands-on approach to sort of our webinars. Like I said, I'm going to be talking about the Opti-O-3 biomarker test. So it's not going to be hugely scientific, but hopefully it will give you some really good, strong information about how our Opti-O-3 biomarker test works, who to sort of use it for, and how to interpret the results. So if you're a practitioner who's either currently using omega-3 or if you're planning to use omega-3 in your practice, then this webinar will provide really invaluable information on how you can optimize omega-3 dosing based on your client's personal omega-3 requirements. Some of you will be familiar with our fatty acid screening service, and you may already be using it. I know that some of the practitioners that are on our books have already used it on themselves. And some of you may be considering using it in your practice and just want a little more information. So for those of you who are considering using our Opti-O-3 biomarker test, we do advise that you use it in conjunction with our Restore and Maintain treatment program, successful intervention and successful results. So today I'm going to be talking about how the Opti-O-3 biomarker test works, and I'll talking a little bit about the fatty acids that we screen for. I'll talk about how we or why we need to determine our baseline omega-3 fatty acid levels, how personalized dosing can help optimize clinical outcomes for your client, and how to interpret the result, what the biomarkers actually mean. So this is our Opti-O-3. Unlike standard sort of fatty acid profiling tests, so there are a few sort of labs that offer sort of fatty acid testing. Our recommendations are focused and based on very specific health biomarkers. So we look at the omega-3 index. This is the amount of EPA and DHA within our red blood cells, and it's expressed as a percentage of the total amount of fatty acids. So in this case, we screen for 26 different fatty acids, and so it's expressed as a percentage of those. And the omega-3 index is a validated sort of biomarker of cardiovascular risk, if you like. The omega-6 to omega-3 ratio, many practitioners sort of familiar with this ratio, and it's a well-established marker, sort of like long-term health, and also of sort of chronic illness. Whilst the omega-6 to omega-3 ratio does give us some information, we are now at a stage in the science where we start to understand that actually it's the specific long-chain omega-6 fatty acid AA, arachidonic acid, and the long-chain omega-3 fatty acid EPA, eicosapentaenoic acid. It's the ratio of these two specific fatty acids that really give us a sort of comprehensive overview of our inflammatory status. And so the AA to EPA ratio gives us a sort of measure of silent or chronic sort of inflammation. And so using these biomarkers, we can offer you a personalized plan that aims to achieve an omega-3 index of more than 8%, omega-6 to omega-3 ratio between 3 and 4, and an AA to EPA ratio between 1.5 and 3. And I'll be going into these biomarkers in a little bit more detail in the sort of next 15 minutes or so. So really, what we need to sort of look at is why we need to be supplementing in the first place, and why fatty acid profiling is an essential part of that treatment. So we know that sort of within the UK population, we don't consume adequate amounts of omega-3 fatty acids in our diet in the form of long-chain fatty acids, EPA and DHA, that are found in marine foods such as fish or fish oil alternatively. We know that low intake omega-3 is having adverse and detrimental effects on our health. One of the key consequences of low dietary intake is the impact that it actually has on inflammatory status. And it's very highly likely that if you are seeing clients with inflammatory related conditions, that they will be deficient in long-chain fatty acids, so EPA and DHA specifically. And when I'm talking about inflammatory related conditions, some of them are sort of like sort of come to mind, and they're very obvious, things like arthritis, some sort of cardiovascular disease, but anything through from sort of diabetes to depression to cancer, all have a sort of inflammatory sort of status behind them. Oh, just a quick intervention as well. Anybody who's got any questions? Yes, I could see some tapping going away. Yes, there is an aspect of omega-3 deficiency and sort of inflammation. So anybody who wants to ask any questions, kind of dealing with those at the end of the talk, if that's okay. It's not going to be a particularly long talk tonight, so we've got lots of question time for you. Okay, so we know that low levels of omega-3 have sort of adverse effects on our health, and unsurprisingly, if we raise our omega-3 levels, this can have significant health benefits. We know from epidemiological studies, we know from dietary intervention studies that individuals who have the highest levels of omega-3, and I'm talking predominantly EPA and DHA, so long chain omega-3 fatty acids, have a significantly reduced risk of developing chronic disease. And as such, raising omega-3 levels are known to exert many beneficial health effects. And there's a lot of focus on using omega-3, obviously, for prevention, but there's also a lot of focus on using omega-3 treatment for the sort of treatment of chronic disease as well. And in fact, if you look on sort of science databases such as PubMed, you will find that there are thousands upon thousands of published dietary intervention studies that have used omega-3 fatty acids, some successfully, but what we find is that quite often we find that intervention studies produce inconsistent findings. There's a lot of sort of a need for sort of clarity as to why some of these studies are producing either inconsistent findings, so either negative or neutral findings. We also find as practitioners that our patients don't always respond to treatment. So while some patients do respond, others don't. And we start sort of asking these questions as why are we sort of seeing these patterns? Why do intervention studies produce inconsistent findings? Why do patients respond differently to very similar treatments? Okay, so part of the reason is that if we look at interventions, so if we look at trials, the majority of them will adopt this sort of one size fits all. So you take a population of people and you treat them with set amounts of omega-3, and then you follow them and you find out sort of what happens. At the individual level, if we're sort of looking at sort of clients and patients on the individual sort of status, we usually sort of focus on manufacturer sort of recommendations. At Igennus, all of our sort of dosing guidance is based on sort of scientific studies. So, for example, for intervention for depression, for example, we know that 1 gram of pure EPA is an effective treatment. But again, sort of using this one size fits all approach without taking account or into account any of the variables that influence the impact of an omega-3 supplement has on somebody's blood levels themselves. The whole purpose of taking an omega-3 supplement is to raise our blood levels. It's not surprising that we can see that different people respond differently. So if I take a gram of omega-3 fatty acids, it's going to have a different effect possibly than if my client takes 1 gram of omega-3 fatty acids. So we start sort of looking at these things. What we do know is that the two major sort of variables are body weight and omega-3 baseline levels, so our sort of starting omega-3 levels. And I've already kind of mentioned the fact that many of us are not consuming adequate amounts of omega-3, so not surprisingly, many of us have got very low omega-3 baseline levels. And we are sort of metabolically unique. And this is the sort of key to sort of intervention, is understanding that we all respond differently, but we can use biomarkers to identify personal requirements for omega-3. And this can help to optimize clinical outcomes. So the whole purpose of intervention is to raise omega-3 levels for clinical outcomes. And if we know body weight and we know omega-3 baseline levels, we can personalize dosing. However, also interesting is that it's very well established that there is extremely high levels of inter-individual variability in how we respond. So as I've said, how I respond and how my client responds are going to be very different. And this is just a sort of a little graph or a little table I've put in from a study published in 2010 to sort of help clarify this. So it was 40 individuals with omega-3 index of less than 5%. So dark line here is the sort of starting baseline levels. Each of the individuals were treated for 6 weeks with 0.5 gram of long-chain omega-3. And then the omega-3 index was evaluated again. And as you can see, each individual responds very differently. So some people's omega-3 index increased, doubled almost, whereas other people's sort of hardly was touched at all. So this huge inter-individual variability in response is very, very high. What we also know is that it's generally accepted that in order to reach a sort of therapeutic sort of status, omega-3 levels have to be around about 8%. A lot of the evidence for this has come from sort of cardiovascular studies, for example. And the importance of reaching an omega-3 index of about 8% is sort of coming through with the sort of recommendations that we're beginning to see. And in fact, there are suggestions that incorporating fatty acid biomarkers actually into trial designs and recruiting participants who have low omega-3 index, coupled primarily with a high AA to EPA ratio, treating them with sort of pre-specified clinically effective targets range, so sort of optimizing their omega-3 index to between 8 and 9% and their AA to EPA ratio between sort of 1.5 and 3 can help to sort of elucidate the effectiveness of omega-3 fatty acids within sort of interventions. And this is the whole sort of focus of the Opti-O-3 really, and the sort of integration with the restore and maintain is to optimize the effectiveness of treatment protocols for sort of clients. So I've mentioned biomarkers. We look at our biomarkers, so the omega-3 index, the omega-6 to omega-3 ratio, and the AA-BPA ratio. To obtain these biomarkers, we need to screen for fatty acids. So we screen for saturated fats, trans fats, monounsaturated fats, and obviously the polyunsaturated fats, omega-6 and omega-3. And we screen for 26 fatty acids in total. Now, different labs do offer sort of omega-3 testing. But what we'll find is that different laboratories screen for different fatty acids. Some will only screen for the sort of major contributing fatty acids and will leave out the sort of minor ones. And therefore, it's very difficult to sort of directly compare biomarker results with other laboratories. And this is in part because when we look at the omega-3 index, it's expressed as the EPA and DHA content of our red blood cell membranes, expressed as a percentage of the total identified red blood cell fatty acids. So the more you screen for, or the less you screen for, it's going to have an impact on your omega-3 index. Now, we choose to screen for the following fatty acids. These are the fatty acids that we screen for. And this is because the profile that we have here is the closest or has the highest correlation with the fatty acids that are screened for in the sort of development of the validated version of the omega-3 index. So our omega-3 index is highly correlated with published data. So we've got 6 saturated, we've got 4 monounsaturated, we've got 7 omega-6, 4 omega-3, and then we've got 3 trans fatty acids. So there are fatty acids. Now, the key advantage of the Opti-O-3 fatty acid biomarker test is that it can be used at them by your client. It can be used by the client themselves, or so we can use it on adults, but we can use it on children as well. So we're finding that a lot of practitioners are actually using it to sort of identify fatty acid profiles on children. The nice thing about this is that it obviously doesn't require a phlebotomist to take a blood sample, so we get a lower cost. Right, okay, so the purpose of this slide is to sort of highlight the fact that dried blood spot, EPA and DHA, is highly correlated with red blood cell EPA and DHA. So red blood cells, sorry, EPA and DHA, is derived from whole blood. Dried blood spot is derived from red blood cell and plasma. Another purpose of putting this slide in is to highlight the fact that when we make our recommendations, we do sort of highlight the importance of fasting overnight. And the reason that we need to fast is that any fatty acids that we take in are obviously going to affect our plasma levels, and we don't want them to affect plasma levels. So we just want to look at red blood cell membranes. So fasting overnight, ideally we do the blood spot first thing on a Monday so that you can post it directly to us so that it doesn't sit around for too long, and primarily sort of before breakfast time. So you can have a glass of water or a sort of drink of water, but ideally nothing to eat from bedtime the night before. Okay, so next slide is what do we get in our kit? And this is where I get interactive. So what do we get in our kit? This is our kit. Comes in a nice little flat box kit, so we can post it directly. This can go directly to your client, or you can stock this in your practice. And what do we get in our kit? So the first thing that we get is we've got a personal information sheet. Now, as you will be advising your clients, we'll go through the test results in a moment, but it's worth just taking some notes from them as well. So we find out a sort of list of things. So we include things like any health conditions they have, obviously, the key symptoms. We ask them about their medication intake. We ask them about any food supplements they're taking, especially omega-3 fatty acids. We also ask them about their fish consumption. Are you vegetarian? Are you vegan? And it gives us a kind of pattern of behavior that when we start to look at their results, can give us a sort of better indication of what's going on. Okay, so that's the first thing we get. We also get a nice, very clear, hopefully, for anybody who's had a look at one of these before, we get a blood collection protocol. So nice, clear instructions on how to do the test. Then we have the blood spot saver card. So if I get this out and show you, this comes in a little bag. in it we include a little moisture absorbent gel sachet. That's to keep your blood spot nice and dry. And as you can see, here we have, so we've got 5 circles, and ideally we would like you to fill one of those to the edges. So if I pop my slide down, here's some nice pictures for you to show you what's in it. So ideally, blood spot should fill the whole circle. We only need one, but we do need one. So the 4 there is just a sort of standard blood spot saver card. So they're used for a variety of different tests, but we just need one to the edges. Okay. So this is our Lancet. We provide 2 of these for you. We have found that some people have struggled a little bit to get some blood or adequate amount of blood. So we give you two of these little numbers. We give you a little wipe to wipe your finger with. Now, it's quite important that before you start to think about taking the blood sample itself, you need to wash your hands, get them nicely, get the blood circulating nicely. Not everybody bleeds very easily, so let me sort of puff our finger up nicely. Get it, all the blood flowing, shake them about if needs be. And then when we're ready to take the sample itself, we open our little sachet, clean our finger, let that dry so that the alcohol evaporates, and then we're ready to use our Lancet. So as you can see in the picture, this is quite important as well, there are actually 3 settings. So it's automatically set on the middle. It's not particularly painful, but so if you accidentally twist this, you will change the setting. Some people may need to sort of go down onto this deep setting if they struggle with the first one. Now, there's a bit of a knack to getting this off, and if I can get this in front of the camera. So we hold, take the end, twist, and pull. And then we are ready to take the blood sample. So where we are, the thing on the end of the finger, push it down, and then you have some blood. We then use that to fill our circle, and then hopefully you should have one of these, or your client should have one of these. Let it dry out for, I think we recommend about an hour or so, but it's within the it's written in the instructions. So once you have your blood sample, you pop it back into the bag as such, squeeze out the air, seal the bag, and then you pop it into this. There will be a stamp on here as well, prepaid envelope. Pop it back to us, and our laboratory analyzes it. Usually we try to have the results back within about 2 to 3 weeks. There's a little turnover time, and once we have our results, we can give you some very valuable information. And now I'm going to talk about how using your fatty acid results can be used as biomarkers of health and disease. So as I've stated, we have our omega-3 index, which is our sort of structural biomarker. It tells us exactly how much omega-3 we've got in our red blood cell membrane, so EPA and DHA, so that's our structural biomarker. We then have our AA to EPA ratio, which is our biomarker of sort of pro-inflammatory products to anti-inflammatory products. And this is important because it tells us our inflammatory status. And so if we look at our omega-3 index first, so as I've said, this is a validated biomarker of cardiovascular health. The data has sort of come to, or has arisen from a number of sort of observational studies and dietary intervention studies. And we know that individuals who have the lowest amount of omega-3 fatty acids within their red blood cell membrane, so if you're about 4% of total fatty acids, then you have very low protection against sort of developing cardiovascular disease. And then when we get to the sort of 8 to 10%, we have the greatest protection. And not surprisingly, populations who have the highest fish intake will have the highest levels of omega-3 fatty acids within their red blood cell membranes, and they have the greatest protection against cardiovascular disease. If you are consuming a Western style diet, it is likely that your omega-3 index is going to be within this range. And the results that we're sort of seeing specifically, we're finding that people are sort of around about here, anywhere between about 4 to 6%. We get the odd person sort of in this sort of greatest protection area, but generally it's sort of between about 4 and 6%. Okay, so our AA to EPA ratio, we use this as a biomarker of pro-inflammatory to anti-inflammatory balance. So our arachidonic acid, which is our main omega-6 fatty acid, gives rise to pro-inflammatory products. EPA gives rise to anti-inflammatory products, and the balance between the two gives us valuable information on our inflammatory status. So ideally, and again, we have our high omega-3 consuming populations, Greenland Inuits, Japanese, very high levels of intake. Their AA to EPA ratio falls within about sort of 1.5 to 3, anywhere up to about 7. Again, Western populations, the less omega-3 you eat, the higher your AA to EPA ratio. So anywhere ideally between about 1.5 to 3, but sort of between about 3 and 7 is considered to be acceptable, although sort of, you know, reducing it down is going to be beneficial. When we get to sort of 20 and above, we're starting to see the AA to EPA ratio being published more and more as a disease biomarker. So especially for sort of conditions such as cardiovascular disease and cancer, for example. So very high AA to EPA ratio gives us an indication of the sort of disease progression in many cases. And as you would expect, there is a correlation between the omega-3 index and the AA to EPA ratio. So the higher your omega-3 index, the lower your AA to EPA ratio, which is what we want. This is a nice sort of healthy sort of status, and obviously vice versa. So the lower your omega-3 index, the higher your AA to EPA ratio. And so that's kind of the test itself. I'm going to talk a little bit about the results in a minute and how we sort of interpret them. And the whole sort of purpose of using the Optio in combination with our Restore and Maintain is this sort of nutritional approach to managing inflammation. We are shifting the balance, and we know that AA, EPA, and DHA contents of our cell membrane can be altered through the consumption of omega-3 fats, either through sort of marine products, or sort of fish, for example, and marine oils, excuse me. Excuse me. And if we change our fatty acid composition of our cell membranes, we get improved cardiovascular health, we get improved cognitive function, we can improve our immune function, and significant improvements in inflammatory resolution. And overall, we can reduce our risk of disease. But this is the key question that we ask or get asked, is how much omega-3 do we need to obtain these kind of health benefits? Okay, so, and this is the purpose of the omega-3 Opti-O-3 biomarker test. So now I'm going to just sort of talk a little bit about the results and the recommendations and how we can optimize our omega-3 levels through personalized dosing. So we tell you, based on your clients' baseline levels and their body weight, exactly how much omega-3 they need to be taking to optimize their omega-3 index and to optimize their AA to EPA ratio. So when you get your results back, or when you get your client gets their results back, they'll receive a lovely little report that looks a little bit like this. So this slide here is taken from the front page. And you probably can't see the writing very, very clearly, but it's just an indication of the 26 different fatty acids. We give you total, saturated, monounsaturated, and so on. And then we have our biomarker results at the bottom. Now you will see, the first thing that you'll see is that we only provide the results, we don't provide reference ranges. Now we have had a few practitioners who have said, what are the reference ranges? What do I need to be sort of looking at? There's a very good reason why we don't provide reference ranges, and that's because there are no validated reference ranges for individual fatty acids. Now, as I've said, there are a few laboratories that offer fatty acid profiling, usually not on dried blood spot, but sort of whole blood. And they do provide reference ranges, but they provide the reference ranges using their own in-house data. If you're providing in-house data from clients who are coming to you with sort of inflammatory conditions or conditions that are related to low omega-3 status, then it's not going to be surprising that the data is skewed because it fails to provide information that has been gathered from what we would consider to be a normal population. So we don't provide reference ranges, and so our recommendations are purely on validated and recognized biomarkers. However, just as a sort of an example of what we have if we were to provide reference ranges, this is just I'm just going to sort of provide a little bit of data here on our omega-3. So we analyze 4 different omega-3 fatty acids. So we've got ALA, which is our short chain. Then we've got EPA and DHA, which in combination provide information on our omega-3 index. Currently, our average, based on all the analysis that we've conducted so far, we're seeing a sort of average EPA level of about 2, with a range from anywhere from 0.2 through to 9. So you can see there's a huge range there. It's very difficult to sort of establish what we should really be looking for. And again, similar with DHA. So our average is about 3.75 with a low of just under 1 and a high of just under 9. So, you know, if we provide those reference ranges, what do we do with them? If we provide reference ranges based on our biomarkers, we can start to get a little bit more information. So, for example, at the moment, our average omega-3 index is coming out at just under 6, with a low of just over 1 and a high, it's quite a remarkable one, of just under 18. And I have mentioned the fact that some of our practitioners have been doing this test on their own, so on themselves. So it's not surprising that we've got a few high ones in there. And average AA to EPA ratio is about 9, with a low of just under 2 and a high of 31.75. So we can see that there's high degrees of sort of inflammation. So on their own, they don't tell us a huge amount, but if we actually sort of put them into our biomarkers, we can start to sort of look at where we should be fitting. We can see that the average AA to EPA ratio, for example, here is 9, which is kind of in the suboptimal, which is not really very surprising given that the majority of people that are coming to us for fatty acid analysis are relatively inflamed or have conditions with high degrees conditions with high degrees of inflammation. Our lowest is 1.83, so we are finding that some people are sort of fitting into this optimal, and our highest is off the scale here at 31.75. So again, there's this huge sort of variability in the results, but putting them into our sort of biomarker diagram here, we start to be able to get a little bit more of a clear idea of where we are and what we should be doing. Okay. Interestingly, and I've talked about the importance of identifying omega-3 baseline levels. So currently, our average is just under 6, our highest is 17, and our lowest is 1.2%. So, for example, if we were to take everybody that we've screened for and without taking into consideration their baseline levels, and we gave them all 1 gram of omega-3, it wouldn't be that surprising to find that not everybody is responsive. So this is why identifying baseline levels are really, really important, because if your baseline level is 1.2, in order to get it up to a nice healthy level of say 8%, 10%, then it's likely that you're going to be needing a lot more omega-3 than somebody who has got a starting level of 5.9. So normally, if you're seeing clients, you wouldn't have this information. It's very difficult to know how to optimize their treatment accordingly. Right, so I'm just going to run through a couple of examples. So, for example, we've got subject A. I haven't provided the whole list of fatty acids here. I've just provided the information on the biomarkers themselves. So, subject A has an omega-3 index of 3.42, so it's relatively low, as we'll see in a moment. An omega-6 to omega-3 ratio that's slightly elevated at 6.34, and an AA to EPA ratio that is highly elevated. And if we then put them into our sort of biomarker panel, this is how the results actually appear in the report itself. So we've tried to keep it sort of fairly simple, fairly easy to understand. So this individual, their omega-3 index is 3.42. We know their body weight, and using a predictive model, we can estimate that their requirements to raise their omega-3 index from 3.42 to 10% based on a body weight of 55 kilograms would be 1.7 grams of omega-3, and this equates to about 30 milligram per kilogram dose. So importantly, if your client was 77 kilograms, for example, they would need about 2.3 grams. So you know, the heavier that we are, obviously, we need more omega-3 fatty acids to raise our omega-3 index to sort of between 8 and 10%. And this is the uniqueness about the Opti-O-3 that you don't get with other biomarker tests or other fatty acid profiling tests, is that we can give you an indication of how much you need to take to raise your omega-3 index. And then if we look at this individual's AA to EPA ratio, just in the red here, we can see that it's 18.27, which is in the sort of poor area. And we need to really get that down. And with the majority of conditions that we are seeing, inflammation is a key factor behind or treating inflammation is a key sort of factor behind the whole treatment process itself. And we do find that an initial sort of 6 months of pure EPA helps to sort of restore a more healthy AA to EPA ratio. So our initial recommendations are to start on Farm EPA Restore, pure EPA at the recommended dose. So I think it was 1.7 grams for at least 6 months. When we have sort of dealt with the high AA to EPA ratio, we can consider introducing DHA possibly for long-term maintenance. So that was subject A. Subject B has an omega-3 index of slightly more favorable, so we're getting close to the sort of 8%. Omega-6 to omega-3 ratio is 3.5, so it's relatively optimal. The AA to EPA ratio is a lot more favorable as well at 4.6. So if you recall, we're looking at sort of getting the AA to EPA ratio between 1.5 and 3. So not surprisingly, this individual's body weight is 50 kilograms. We're only raising or attempting to raise the omega-3 index from 7.24 up to 10. We kind of over estimate. Ideally, we should be looking at 8, but we kind of go for 10 for optimal outcomes. And this individual's requirements would be around 0.6 grams of omega-3 daily. And that would equate to a dose of around about 11 milligrams per kilogram. So again, a 77 kilo person would need to take slightly more at about 0.85 grams, so 850 milligrams. And again, we generally recommend a sort of initial loading dose of pure EPA to help optimize the AA to EPA ratio. So we tackle the inflammatory sort of aspect first, and then we sort of introduce DHA at a later stage for long-term sort of maintenance of both the omega-3 index and the AA to EPA ratio. So this is really the kind of focus. So as I've said, this is the kind of report that you will get, and it's very similar to what I've just shown you on the screen. The recommendations really focus on sort of optimizing the dose to reduce the AA to EPA ratio and to increase the omega-3 index. We do provide obviously all the different types of fatty acids. For the nutritionists out there, this can be quite useful. For those of you who aren't necessarily nutritionists, it's just a bit of extra information. You don't need to pay too much attention to this. It's the biomarkers that are of interest, and it's optimizing these biomarkers that should be the focus of your recommendations. And just to sort of throw a little case study in at the end, so this is an example of a 4-month intervention using pure EPA at a dose of 1.5 grams. So this was based on an individual's baseline level of 3.5 for the omega-3 index, 8.52 for the AA to EPA ratio. So we can see that the omega-3 index starting point was undesirable. AA to EPA ratio was suboptimal, so quite high, omega-3 index quite low. And based on this individual's body weight, the dose was 1.5 grams. They then retested at 4 months. We generally sort of recommend sort of 6 months to sort of give the fatty acids a sort of a scope to sort of get kicked in, really. But after 4 months, there was a considerable change, actually. So after 4 months, the omega-3 index had increased from 3.5 to just under 6. So we went from undesirable into desirable. So it was a change of 2.48%. And the AA to EPA ratio was reduced, so almost by half, in fact. So it went from suboptimal down to acceptable. So we know that intervention works. We know that using the omega-3 index baseline levels, we can start to sort of follow these individuals, and we can look at their progress. And we often see that the symptoms that are related to the sort of initial baseline levels, we see improvement in symptoms as well, which is incredibly encouraging. So I'm reaching the end of the talk. I'm just going to sort of highlight some of the benefits that can be obtained from using the Opti-O-3. So it's a kind of a little bit of a summary, really. So as practitioners, getting this sort of initial knowledge of baseline levels helps you to sort of guide your recommendations. And we know that low baseline values require much higher doses than individuals who've got higher baseline levels. And this is kind of common sense, really. What we're finding is that the results that we're getting through, some of the recommendations for omega-3 intervention are ranging from anywhere from sort of 1 gram up to 4 grams per day. And given that a lot of sort of recommendations or manufacturers' recommendations are sort of 1 capsule, 2 capsules, sort of 0.5 gram, 1 gram, it's not surprising that many interventions have sort of failed to sort of achieve the health benefits that we would ideally like them to achieve. So higher doses, it's not surprising that we're seeing these higher doses given the low levels of omega-3 and the high AA to EPA ratios that are coming back. And so these biomarkers are invaluable for assessing both the baseline risk, and so we get our baseline, but also in the change in risk. So what I mean by that is the improvement as a function of intake. And what's quite nice is that when clients can actually visualize their sort of deficiencies, if you like, it really kind of encourages compliance to treatment interventions. So people can see what their levels are, it encourages them to sort of stick to the protocol, if you like. And then when they retest after sort of between six months and a year, they can start to sort of see not only improvements in symptoms, but also improvements actually in their biomarkers. So yes, obviously dose response studies show us that higher doses of omega-3 are generally required to reduce the AA to EPA ratio and to achieve an omega-3 index of 8% or more, especially when baseline levels are particularly low. So if baseline levels are under 4, you need really high sort of intake of omega-3 to get that level back up to 8. So that's the benefits of using the Opti-O-3. Using it in conjunction with the Epa Restore and Maintain is going to add sort of even more value to your sort of treatment protocol. We generally advise preloading with pure EPA, and that helps to deal with sort of any underlying inflammation. And this helps to reduce the AA to EPA ratio. And then at a later date, we can then start considering introducing DHA for sort of long-term support of the omega-3 index, as well as the AA to EPA ratio. So that was the final slide, and that's me. This is me with my lovely headphones on. Thank you very much for taking some time out. I hope that that has provided some interesting information for you. I'm now going to have a look at some of the questions. I may invite, I do believe that Sophie has joined me, or Sophie has joined me some time ago.
Hello.
Ah, I think Sophie may have some information about offers and
yes, certainly. Yes. For obviously this webinar has hopefully been very helpful for most of you, and it kind of teased out any issues that people are having with doing the follow-up consultations and things like that. For those of you who haven't been able to try it yourselves already, or who do need a little bit of a kind of incentive to get going with things, we are actually offering a free box of the Epa Restore or an omega product of your choice with every purchase of the omega-3 test in the coming month. In terms of cost, somebody did ask a bit earlier how much it costs. It's £78 inclusive of VAT for practitioners at the trade rate. So if you do have a practitioner account with us, that's how much it costs. £65 ex VAT. Obviously, you do need to have a practitioner account directly with us to be able to purchase the Opti-O-3 at the moment. Because we use our own lab, it's not possible to make it available as a product through the likes of Nutricentre or Vital natural dispensary schemes just yet. But as I say, if you want to try that yourselves, then we are automatically giving everybody a box of product just to get you going, so that you save the equivalent of £30 on product. It can be applied to clients as well. So if you're ordering at the trade rate for your client, they will also get the box of product free. So we just want to give you a little bit of an incentive to kind of try it out going with a few people. So it's the equivalent of an up to £30 saving on that one. So Nina, I don't know whether you've had a chance to look back through questions, but I did scribble them down as we went. So I don't know whether you want me to kind of read
right,
them out.
okay.
Is that easier, or have we found them all?
Right, I'm coming through. Okay, yes. Dun, 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 dun. Right, okay. So, hello, Gabby. Yes, children with autism. There is an association between low omega-3 and high AA to EPA ratio in children with autism. And there is increasing interest in the use of omega-3 in the treatment of autism as well. So comes under the whole kind of spectrum of neurodevelopmental disorders. Much of the sort of science has kind of really focused on conditions such as ADHD, but the kind of symptoms and the correlations are very, very similar. So we know that intervention with children with autism can be very successful. In regards to supplementing with children aged 3 to 8 with omega-3, again, there are no sort of general recommendations for, I mean, the recommendations that are set, sort of government recommendations, are that we should be consuming about 0.5 gram of preformed omega-3 every day. Now, that's kind of highlighted in adults. There doesn't seem to be any sort of recommendations for children. So we would sort of suggest that looking at sort of obtaining the best sort of omega-3 index and AA to EPA ratio is probably more the way to go. And again, this is about sort of biomarker status as well. We do know that our intake of omega-3 is reducing as well. So we're not even sort of matching half of the amount the government are recommending. Children especially seem to be eating less and less sort of oily fish, for example. So it's not surprising that the deficiencies that we're sort of seeing coming out in sort of scientific papers are sort of correlating with some of the sort of childhood diseases and conditions that are also sort of becoming quite predominant as well. So I hope that sort of answers that. I'm just having a look to see. So, I mean, just going back to that, actually, we do have practitioners who specialize in sort of children's disorders, and they quite successfully use anywhere between sort of 0.5 gram up to about 1 gram for sort of children aged, I'm not sure about maybe age 3, but sort of maybe 200 milligrams to 500 milligrams for a child age 3, depending on if you're sort of looking at sort of intervention for sort of inflammatory related conditions. So for sort of general health, I would suggest maybe sort of 200, 250 would be absolutely adequate. You may need a little bit more if you're looking at sort of intervention for inflammatory conditions. Right, okay. Yes, okay, 2 Lancets. We should be sending out 2 Lancets with every omega-3 kit. Now, we did originally put 1 Lancet in, but we did find that we were getting reports that some people were sort of struggling to get adequate amounts of blood, and then sort of feeling a little bit lost as to quite what to do after that. Okay, right. Sophie's covered the price of the kits. CRP is the most commonly used acute marker of bio. Okay, that was an answer. Excuse me whilst I'm just. Yes, there are no reference ranges. How can Right, if there are no reference ranges, how can we say too little causes disease? Right, okay, the whole sort of correlation between omega-3 levels are actually based on biomarkers. So the omega-3 index, as I said, it was originally validated for cardiovascular disease. We're now beginning to see very low omega-3 index in conditions such as metabolic syndrome, diabetes, depression, cancer, and there is a direct correlation between sort of disease state or sort of disease risk and low omega-3 levels, so EPA and DHA. So not when we're talking about reference ranges, we're talking about reference ranges for individual fatty acids themselves. When we put them into sort of applied biomarkers, it provides us with a lot more sort of comprehensive information on how omega-3 levels themselves correlate with disease risk. Yes, absolutely. Hazel, can we use this test for CFS-ME patients for prescribing the GPAT? Absolutely, yes. Okay, Lucille, I think Sophie has covered the information. So within our kit, we do give individuals information sheet to fill in. They give us an indication of their dietary intake. So their fatty acid biomarker results are based on their current intake of omega-3, and I think it does state within the report that the recommendations that we make are based on as an addition to their current omega-3 intake. It's really quite surprising, actually, and slightly shocking as well, that we are seeing some of the sort of very low levels in some individuals, even when they're sort of saying that they're routinely sort of consuming oily fish and sort of supplementing as well with omega-3 supplements themselves. Okay, so and then I've got a question from Lucille. Is there anything specific which inhibits the absorption of EPA? Some of the factors that we do know that can lower the absorption of omega-3 is if you take them on an empty stomach, if you don't have enough sort of fatty acids, if you don't have enough fat at the same time. So in order to sort of digest and absorb, we need to release various enzymes, so lipase enzymes, to help us sort of uptake fatty acids. One of the sort of key issues that have sort of been reported from some of the dietary intervention studies is that people are taking them at the wrong time of day, for example. So if you're not taking them with a fatty meal, ideally to optimize uptake, it can reduce the bioavailability. On saying that, there are different types of forms of fatty acids. So we used to, or we have got some of our forms of fish oil are in ethyl ester. We have recently brought out a range of re-esterified triglycerides as a response to some of the sort of literature findings that are clearly showing that the bioavailability of re-esterified triglyceride is superior to just about anything else on the market, even krill. So there's a lot of very inaccurate marketing of krill, by the way, at the moment. So this sort of whole concept that krill is highly bioavailable, the sort of scientific reviews that are coming out are basically saying that there is not enough validated sort of science behind krill absorption, especially in the very low doses that the sort of marketing is sort of suggesting that we need to take. So this whole kind of concept of a one-a-day krill pill really doesn't cut the mustard when we're thinking about sort of trying to achieve a nice high omega-3 index. So we need highly concentrated, highly bioavailable, and we need them in high doses if we're going to optimize our health. Right. Hopefully we have covered some of the questions. Same dosing apply for algae omega-3 oils. Now, the only issue with algae omega-3 oils at the moment is that the majority of preformed algae is DHA only, or very high DHA, very low EPA. To lower the AA to EPA ratio, you need high concentration EPA. So I would suggest that probably algae may not lower your your AA to EPA ratio as effectively as preformed EPA. We are also on the lookout for a pure EPA algae source as well for the sort of vegetarians and vegans. So at the moment, pure EPA is the most effective way of reducing the AA to EPA ratio, and it also increases the omega-3 index, which is quite encouraging. Is there a known impact on childhood eczema of right, sorry, Lucille, is your question omega-3 deficiency? I believe if you know any differently, Sophie, then do please intervene. Omega-3 deficiency can increase the chance of developing eczema, and I know that parents or mothers who do not consume preformed omega-3 during pregnancy increases the risk of childhood eczema. I think that's correct.
Yeah, as far as I know, Nina, there's
Yeah,
definitely sort of a link between low omega-3 status, high inflammation, likely
and
to
sort
develop
of general allergies as
anti-eczema
well.
things
Yeah.
and stuff like that. Yeah, exactly. I just want to intervene really quickly, Nina, sorry, because
Mm.
Gabby actually asked a question earlier on about
Oh,
whether or not the Opti-O-3 and biomarkers of inflammation would be useful for women with hormonal issues. So I'm sure you've got something to say about that. So I'm hoping to do it.
Right, absolutely. Well, yes, hormonal issues. Yes, I don't see why not, actually. Generally, when there is hormonal issues, that we do have sort of relatively high levels of inflammation. So it would certainly give sort of an indication to some extent of that. I don't know if you have any sort of specific interventions there, Sophie, if you know of anything particular that can relate biomarker testing with when we're talking about hormonal issues. I'm not sure. Are we talking about sort of
Yeah, I mean,
menopausal or?
yeah, I mean, it would be helpful, certainly, Gabby, if you wanted to email us. Education@Igennus is a good way to get
Mm,
hold of us to just clarify a little bit more. But certainly, with things like PMT,
yeah.
endometriosis, and stuff like that, a lot of the pain associated with those hormonal issues is actually as a result of high cytokine production. So the higher your inflammation, the higher your cytokine production, the more
Mm,
likely you are to suffer from very bad sort of cramping pains and things like that. So
yeah.
relating specifically to that, then yes, certainly EPA is very helpful. But with regard to more other things, then it'd be useful to know specifically what your interests are and you find out. Okay,
Right.
you said perfect
Okay.
answer, so that sounds like that's what we
Oh,
wanted to hear. Good stuff. Back to
okay.
you then, Nina. There's a
Right.
couple more
Hopefully
questions, and then
that's
we'll have
answered
to
that one.
call it.
Okay. Historical time period. Red blood cell lifespan, I believe, is about 120 days. It which makes it reflective of sort of like long-term dietary sort of intake, whereas plasma can be influenced by sort of immediate sort of intake of omega-3s. So if you eat a fatty meal right now, your plasma levels will increase, but your red blood cell levels won't be affected as significantly. So red blood cell levels give us a much longer sort of dietary information about dietary exposure, long-term dietary exposure. And again, the sort of use of red blood cells has been highly validated as well. So it's very reliable. Next question is, do you have this is omega-3 absorption in someone with intolerance to fat? Gallstones. Gallstones. Oh, okay, thank you, Gabby. Right. Intolerance to fat and gallstones. Right. I don't know. Do you have any information on that one, Sophie? You may be better at answering that one. So somebody with
Just
intolerance to fat.
the overall kind of message with regards to gallstones and gallbladder removal and things like that is,
No.
in realistic terms, it shouldn't actually affect our ability to digest and absorb fats. We can still make bile, we can still release bile into the digestive system. The problem is more often than not, if people have gallstones, have had their gallbladder removed, and they're having issues digesting fat, it's signifying total digestive system. So I'd strongly recommend you check out an article that Kyla Williams wrote for us recently,
Mm.
talking fully about the digestive function, healing the gut, working all the way right from
Mm.
replacing hydrochloric acid, reducing fermenting gut, replacing and healing the digestive tract, and then that will overall help with digestion of fats and supporting general health in terms of being able to fully absorb and utilize fatty foods.
Yeah, I mean, if somebody's had their gallbladder removed, I mean, the sort of best advice really is when you're consuming fat to do it in small doses, really. So, like Sophie says, we're still producing bile, we just don't have the ability to store it. So, omega-3 supplementation in small doses, and in fact, we actually actively encourage people to split dose all of our products to increase the sort of bioavailability and absorption. The uptake is certainly improved if you take it in small doses rather than sort of this whole kind of concept of having giant capsules or one a day and that kind of thing. So split dosing is certainly the way to go, and that will certainly help if anybody has got sort of issues with fat absorption.
I've just copied and pasted the link to the article that I just mentioned if anybody does want to check it out. Basically, on our website, we've got a practitioner-specific blog. We cover all sorts of research topics as well as applied nutrition topics to just try and support all of the different areas that Igennus products, as well as the absorption of fats and the health areas that we specialise in, can be applied. So do check that out if you're not already part of our subscription list, but that's the link specifically to the article where Kyla focuses on restoring and repairing digestive health. So I think Dr. Bailey has exhausted herself with speaking and questions. So thank you once again all very much for coming. If you do have any additional questions that we've not been able to cover this evening, any questions about signing up, practitioner prices, you want to get on our mailing list, then please do email us. You can either get us at Nina B at Igennus, Sophie T at Igennus, or education at Igennus. But from me and Nina, I guess it's thank you very much, over and out, and enjoy the rest of your week.
Yes, thank you very much, everybody, and we'll see you at the next event.